Hi, I'm Dr. Keith Johnson, and I just wanted to say thank you for choosing Family Orthopedics and Dr. Keith Johnson. My staff and I, from the bottom of our hearts, we want to say we are grateful and appreciative of your trust of us to treat your orthopedic conditions. We want you to know that we value you and we value your health, and our number one mission is making sure that you live the most active and productive and happy life you can possibly live. I'm a native El Pasoan, born and raised here. I'm a military brat to some extent. My father was in the Army, ultimately got stationed here right as I was about to be born. So I think I was born at Hotel Dieu, I think, which is now Del Sol or something like that. But I was born in El Paso, raised in El Paso on the east side. I went to Hanks High School. And as a child, I suffered with asthma severely. So my interest in medicine came naturally because I suffered with asthma severely. So I was always in the doctor's office. Orthopedics was more a late decision. When I first decided I wanted to be a physician, I thought I was going to be a pediatric pulmonologist because asthma was my impetus. But along the way, playing sports, soccer, basketball, I'd broken a couple of bones and had visited some doctors here in town. And Dr. Zaltz, who ultimately became my partner years later, he actually set my finger. I broke my small finger playing football. I forget what age, probably 12, 13. And I broke my arm a little bit younger. And so Dr. Zaltz set, I believe, both of those fractures. And I remember him putting an ulnar nerve block in my elbow and just making this side of my hand go completely numb. And as a 12-year-old or however old I was, that was the most magical thing I've ever seen, because he was able to just crack my bone back into place. You know, my finger was pointing off to the left and he cracked it back into place. I didn't feel any pain. So that was, I didn't even know it was called orthopedics at that time, but that again was some familiarity with medicine. And so again, El Paso, Tierra del Sol, Desert View Middle School, Hanks High School, and then I was fortunate enough to go to the University of Notre Dame, where I met my wife. I was fortunate enough to get into medical school in Nashville. I applied to orthopedic residencies and got accepted to the University of Texas, and then just kind of made my way back to Texas. I kind of always thought I would come back to Texas just because that's the place where my roots, you know, that formed my roots. And I felt like growing up, I kind of always heard about the brain drain in El Paso. And I kind of understood that more as I got higher and higher into education, because more and more of my colleagues who are from El Paso weren't returning to El Paso. One of my best friends who went to Harvard and was in residency with me, he's in Houston now, great surgeon. And it just became apparent that not everybody who was molded and nurtured in El Paso felt the obligation to return. So I always had that pulling, partly because my parents, you know, grandparents, parents, cousins, aunts and uncles still live here via the military. I just felt always that I would come back to my community and contribute whatever talents that the community had a hand in developing. El Paso really is a great place for family, and I grew up here with, again, military brat. My dad was brought here by Uncle Sam to Fort Bliss. He settled here, and at the time when I was growing up, most African Americans all lived in the same block or two. So I literally grew up living next door to my cousin, next door to my grandmother. So my uncle and aunt were next door. My grandmother was next door. It was like almost like Leave It to Beaver, like the ultimate family environment. I would get home, we'd all play together. And so that really struck me, you know, the importance of family was really reinforced at that time. I have 4 children of different ages. And my oldest graduated from Baylor in journalism, and she's at Georgetown University getting a master's in journalism as we speak. I'm hoping she'll go to law school after that. That's the goal. My wife's grandfather was one of the first graduates of Howard Law School in DC. So he helped mentor Thurgood Marshall. So there's a little bit of a legacy there. So I'm hoping she'll go to Howard, although she wants to go to Georgetown. And then I have another daughter who just graduated from Notre Dame, which is where my wife and I attended, and she's in New York right now doing an internship, and hopefully she's planning on going to Columbia Film School next semester. I have two children that are younger. I kind of have two sets of kids, an older set and a younger set by the same wife. One wife, 4 kids. So those children are attending private schools in Phoenix right now. But I have my son. I have 3 daughters and a son. My youngest is a son, and he's an athlete, a baseball, basketball player. So again, all of my children spent their formative years in El Paso. My older 2 daughters went to Coronado High School. And El Paso has been amazing for them, and it's been a good launching pad for the entire family. My hobbies include sports. I was an athlete. I still play basketball. I still lift weights. I'm a musician. I still play and write, and I've put some songs on I have a television Christmas special that I wrote a song for that, believe it or not, is on TV. So I write, and that's kind of where my daughters got their creativity from, my daughter who's in film school. So a little bit about just some of the specifics of my practice and my specializations. What I find interesting is patients and people always ask, what is your specialty? What do you like to do? And when I tell them everything, it's hard for them to imagine that I do so many things well, but my interest is diverse. Like, I really do enjoy doing knee replacements, hip replacements, all of the adult reconstruction, shoulder replacements. But I also enjoy doing sports, ACL reconstructions, rotator cuffs, work injuries, fractures. I've always prided myself on learning the cutting edge parts of orthopedics. So I've always prided myself on going to courses and learning what is the latest and greatest there is to offer. Again, that's part of that is my mission to El Paso, to bring whatever the best that medicine has to offer to El Paso. And in that vein, I've started to do a lot more with stem cell treatments. It's funny, as I've gotten further in my career of surgery, I've found myself finding non-surgical treatments for things. So I try to do less surgery and treat things non-surgically. So I do a lot more stem cell PRP type injections and treatments that allow injuries that used to just be surgical for sure to heal, to help the patients to heal on their own. And so you might think that's counterintuitive or counterproductive to a surgeon, but it's something that I've studied quite a bit and provided and offered to my patients. And so I've been able to treat a lot of professional athletes, Division I college athletes who, again, would have otherwise needed surgery or otherwise had to shut down for the season, professional pitchers in Mexico, all kinds of athletes and celebrities who, and what I call everyday heroes, just, good old-fashioned, hardworking El Pasoans. I've been very happy with that. What makes me different as an orthopedic surgeon, I really feel like my bedside manner, I think, again, it honestly goes back to my childhood of being a patient So before I was ever a doctor, I was a patient over and over and over again as a child. So I really learned a lot about patient care from the other side, being a patient. So I carry that with me. When I'm giving my injections in the office, my patients are always saying, you have it doesn't hurt. Like, how do you do a shot and it doesn't hurt at all? And I always relate back to when I was a kid, I had hundreds of injections and they all hurt. And so I've made it my mission to find the secret sauce to making a shot not hurt. Because I can still remember as a kid, having to be held down and get a painful injection. So being a patient, I think sets me, learning from that perspective, from patient to doctor, has made just my bedside manner different. And I think it also goes back to my parents and ministry and church and that sort of thing. All my family members are ministers, my sister, brother, so being in ministry, being a musician, being always in the care and the service of others sort of just refines your bedside manner. So what makes me different, I think I spend a lot of time with patients. I answer their questions. I pride myself on educating the patient about their own bodies. There's two ways to practice medicine. And both ways can be good, but you can be very paternalistic and just tell patients what to do and how to, or you can explain, teach, give them their options, and empower the patients to make their own decisions and follow their gut, even though they may not understand all of the nuances of what their condition is. I always tell my patients, follow your gut. If you feel like a doctor just doesn't care, follow your gut. If you feel like a surgery you don't feel comfortable with it, follow your gut, and until you become comfortable with it. So I pride myself on helping patients to become comfortable understanding their options and make their decision. Now, I try to get my patients in a timely fashion. So if you need to see me, you're going to get in, sometimes same day. The caveat and when you get in to see me, you're going to get plenty of time, FaceTime. I'm not one of these surgeons who are going to come into the room with my face in a computer and sit there and glance up at you. I'm going to look you in the eye the whole visit. My staff is going to do all the computer stuff, and I'm going to examine you and answer your questions and explain everything and essentially give you as much time as you need. The negative of that is you might wait a little longer in the waiting room to see me, but you can get in when you need to get in. And when you do get done with your visit, you will leave feeling heard and feeling treated and be glad that you came. So one of my sort of de facto areas of specialty is the shoulder. Part of that is because I trained in San Antonio with 2 or 3 of the world's best shoulder surgeons. And so I came to El Paso with a level of expertise in the shoulder that other doctors just didn't have. So kind of one of the ways you're a specialist is other orthopedic surgeons send that body part to you. They don't want to deal with it. So I've always had an expertise in the shoulder that has ranged from sports injuries like labral injuries and labral tears, all the way up to rotator cuff injuries, all the way up to shoulder replacement. So shoulder pain is like, if I had to pick one area that I comprehensively treat everything in that particular body part, it would be the shoulder. One of the most common things I see is, of course, just shoulder pain, which falls into multiple areas like rotator cuff syndrome. One of the most highly underdiagnosed things that I see that cause shoulder pain is something called adhesive capsulitis or frozen shoulder. And that's where patients lose range of motion. It becomes extremely painful. Oftentimes that's even more painful than rotator cuff injuries. So Rotator cuff injuries obviously are common and well known, but we treat them with everything from physical therapy to stem cell injections to ultimately arthroscopy. But I've always had sort of extra training, extra expertise when it comes to the shoulder, whether it be shoulder instability, patients, usually younger patients who've dislocated their shoulder traumatically, playing basketball, playing football, repairing that arthroscopically, to more work injuries, rotator cuff tears, both acute, meaning recent, or chronic, meaning it's been tearing for years, and we're treating those again with stem cells, injections, therapy, and ultimately surgery, all the way up to the sort of the furthest extent, which is rotator cuff arthropathy or chronic shoulder arthritis, which is amenable to just shoulder replacement. And so I remember, again, early in my career, seeing patients where a surgeon would go in and sort of scope the shoulder and realize this is over my head, and then waking the patient up and saying, hey, go see Dr. Johnson, or go, I couldn't do this. And so I've always taken pride with being able to do everything in the shoulder. Speaking about internal derangement of the knee, obviously that's a very generic umbrella term, but it's a term that we often have to start with before we refine the diagnosis. So patients come in with knee pain of all sorts and of all ages. Based on your age and your history or mechanism of injury or lack thereof, sort of begins our sort of detective work when it comes to figuring out what that internal derangement is. It could be something as innocent as just inflammation, or inflammation of the fat pad, inflammation of little soft tissue structures, but nothing structurally is actually disrupted. That's more of an inflammatory condition, tendinitis, tendinosis. I've recently done some stem cell injections on some Division I college basketball players who will probably be in the NBA in the next couple of years, who came in with debilitating tendon injuries that had been there for months and if not years, and just with stem cell injections we're able to get them, with one stem cell injection, I was able to get them back on the court dunking and running and playing. So that's been a really big thing recently, both here and in Phoenix. But internal derangements are commonly in younger people meniscal tears of different kinds, and every meniscus tear is different. Obviously ACL, anterior cruciate ligament injuries, which is a big problem in sports. Non-contact ACL injuries is a big problem in women more so than men. And as well, obviously arthritis and fractures, and another really common internal derangement in teenagers is just anterior knee pain, which is kind of its own thing. It could be related to softening of the cartilage, which is chondromalacia. Chondro meaning cartilage, malacia means soft. It could have to do with muscle imbalance and tracking the patella, not tracking correctly. Again, tendinitis or tendinosis of the patellar tendon or the quadriceps tendon. There are just so many things that can fall under the umbrella of internal derangement of the knee, but we treat all of the above. Sometimes we order MRIs to obviously see what the imaging shows. But I always tell my patients, I don't treat MRIs, I treat patients, and sometimes the MRI can lead you astray. So my physical exam corroborates what the MRI says, or fails to corroborate it, conflicts it. And based on, really, I'm usually more confident in my physical exam than I am the MRI, because MRIs can be inaccurate. And so we use both. I'm very, very big on physical exam, putting my hands, examining you, finding the pain, finding the diagnosis first clinically with my hands, and then sending you off for an MRI to see what it says, and then corroborating those two and finding out a treatment plan for you. Speaking about plantar fasciitis, again, that's one of the more common things that we see in the office. It is often someone who's been suffering from it for years because they've been to podiatrists and tons of doctors and just can't figure it out. It's always one of those things, which came first, the chicken or the egg? It's always, did the bone spur come first or did the plantar fasciitis come first? A lot of patients come in thinking, go get the bone spur and the plantar fasciitis will go away. Often it's not as simple as that. But one thing I am very adamant about is doing everything to avoid surgery on the plantar fascia, just because it's a painful procedure, the recovery is long. So I, again, use a lot of non-surgical treatments on plantar fasciitis, everything from exercises and stretches and orthotics and such to, again, PRP and stem cell injections. And the latter, bone marrow aspirate concentrate or stem cell injections, has probably been the most effective treatment. And again, it's the state of the art essentially for medicine in the future. I mean, in the future, there's stem cells are going to treat everything from diabetes to dementia to you name it. And so musculoskeletal conditions, particularly mesenchymal stem cells, which are a particular type of stem cells that come from your bone marrow, are excellent at addressing particularly soft tissue injuries, whether it be plantar fasciitis or Achilles tendonitis, which is right adjacent to the plantar fascia. Those two things oftentimes go hand in hand. Recently, there's been a rash of Achilles injuries in the NBA and in professional sports, and everybody's trying to figure out why, and why are we getting more and more tears. And what I have told some of my friends who work in professional sports, like, if you send those guys to me, I can usually get them fixed with a stem cell shot before they ever tear their Achilles. And I've had a tremendous amount of experience and success with both plantar fasciitis and Achilles tendonitis just with mesenchymal stem cell injections. And I've had patients who've been hurting for years and years and have had every treatment under the sun, from shots to cast boots to therapy, to shots to cast boots to therapy, to this electrical stimulation. And after 2 or 3 weeks after a stem cell injection, all of their pain is gone. So lateral epicondylitis, elbow pain. Lateral epicondylitis is commonly referred to as tennis elbow. And now with, not that many people play tennis, but tons of people play pickleball, especially in Arizona, and it's becoming a popular sport. But you don't have to play tennis or pickleball or golf. Lateral-sided elbow pain is generally referred to as tennis elbow. Medial-sided elbow pain is generally referred to as golfer's elbow. But you don't have to play either sport to have that pain. It's usually a work-related, repetitive type condition. And again, that's one of those areas of orthopedics that's very hard to treat. Generally, people either over-treat it or under-treat it, over-diagnose it or under-diagnose it. And it's something that's one of the most common things we see in the office. And it's usually tolerated or ignored for as long as they possibly can, but it's just a dull achiness in the lateral aspect of the elbow that gets worse at times and better at times. And so again, examination and imaging are the key. Once you have established the diagnosis, in my practice, it's pretty much determining whether there's a physical tear of the tendon, which can be imaged with an MRI, or if there's just inflammation, which is much more common. And that's a lot more difficult to sort of treat. A tear oftentimes can need surgery, but if you're just hurting with inflammation, that's again where physical therapy, bracing, and ultimately, to be repetitive, stem cell injections have been very, very helpful in helping patients to get better without surgery. Rheumatoid arthritis is a specific type of arthritis, different from osteoarthritis. It is a autoimmune type of arthritis that is usually being treated by a medical doctor because the treatment for it is systemic to prevent the progression of it. So rheumatologists all over the city are seeing people with rheumatoid arthritis. Now, by the time you come to see me, it's usually towards the end stage when it's time for a joint replacement. And that's where my specialty comes into effect. So the medical treatment is something that should be done early and often by a rheumatologist to try to slow down the autoimmune degradation of your cartilage. And once all of that fails, that's where the orthopedic surgeon comes in and does a joint replacement. And so we have plenty of patients that have rheumatoid arthritis who ultimately have benefited from our ability to do knee replacements, hip replacements, shoulder replacements. And that's where the treatment of rheumatoid arthritis comes into our practice. Disc degeneration and back pain. I refer all back surgeries out to neurosurgeons or to spine specialists who do surgery, but we see tons of back pain. And back pain is a large spectrum of everything from scoliosis and childhood things such as spondylosis or spondylolisthesis, which is like a stress fracture in a young person, teenager, all the way up to degenerative disc disease or traumatic herniation of a disc. And we see all of that, we treat all of it. The procedures vary from, again, physical therapy and bracing and anti-inflammatories and medications to injections in the office. If it needs more than that, I typically will refer it out to a pain management physician or a spine surgeon. But we see tons of disc disease. It's one of the most common things walking around. And one of the biggest things is correctly diagnosing the cause of pain. So when patients come in and say, for example, I have back pain or I have hip pain, my first question is, well, what do you mean by that? Because oftentimes they're not even referring to their back, they're referring to their sacroiliac joint, which is part of their pelvis. Or they say I have hip pain, but they actually, when I say, well, what do you mean by hip? They point to their back. And so the human body is so well interconnected that sometimes patients or even doctors can confuse a pain here with a problem that is elsewhere. So my biggest thing when it comes to back pain and degenerative disc disease or any of the other causes of back pain is to first get the accurate diagnosis. And once you have that, oftentimes, again, when patients come in and say, I tried physical therapy, it didn't work, I usually respond with, well, the therapist probably didn't have the right diagnosis. If we get the right diagnosis and we give it to the therapist and can refine the treatment, oftentimes physical therapy will magically work. But when they're just sort of doing whatever they can to help and they don't really know what the true cause of pain is, therapy is not as effective. Imagine that. So really the critical part about the office visit is the accurate diagnosis of back pain. When it comes to treatment of foot and ankle conditions, bunions is one of the most common things we see. But when pain is really the issue, obviously the cosmesis is an important part, but pain is what we generally are trying to correct when we correct the bunion deformity. And it certainly is something that when it's interfering with your activity level, your shoe wear, your ability to remain active, and of course, people like their feet to look good, all of that is what is encompassed when we do surgery. And it is a very effective thing that we do. It's something that we do quite often. So osteoarthritis is ubiquitous. There's more osteoarthritis out there than any one orthopedic surgeon can address, and obviously it can affect any body part, from the neck to the back to the shoulder to the hip to the knee. Generally, again, early on, the key is sort of trying to manage it as without surgery, with exercise, with diet, with nutrition, with all non-surgical treatments, anti-inflammatories, and oftentimes the earlier we can address it, the better, non-surgically. There's two areas of osteoarthritis, or I should say two levels of severity that I like to address. So particularly when it comes to knee replacements, a lot of surgeons will tell you when it comes to osteoarthritis of the knee, wait until you can't walk anymore, until it's just so far gone that you just can't take it. Well, I don't particularly agree with that, but that mode of thinking is the majority of surgeons. But because I also do partial knee replacements, robotic MAKOplasties, oftentimes patients come in late asking are they a candidate for the partial knee replacement? And I always am educating patients as to, if you had come to me early, I might have been able to do a small, minimally invasive partial knee replacement, but now you've waited until it's tri-compartmental or it's engulfed your entire knee. Now you need a total knee replacement. Neither operation is bad, but if you're in any way able to get a partial knee, you're going to enjoy that recovery process much better. And that is only possible if they come early. So I'm usually inclined to tell patients, when you have knee pain of any sort, come early. I oftentimes joke with patients, like, I think you guys think we're gonna like kidnap you and tape you down and sort of, or brainwash you or convince you to have surgery. And so a lot of patients are afraid to come to the orthopedic surgeon because they don't want surgery. Well, that's okay. Very little of what, maybe 10% or less of my patients actually need or I recommend surgery. The other 90% we're treating with non-surgical treatments, from diet and exercise to physical therapy to anti-inflammatories to injections of all sorts. So sprains, trains, and automobiles. We see a lot of automobile accidents. We see a lot of sprains, sports injuries. These are soft tissue injuries that can have a variable duration of healing time. While sprains may not seem like something that you should even go to the doctor for, oftentimes injuries are more than a sprain. So whether it be physical exam or MRIs, it's always good to know the extent of the injury, even if you don't need surgery or any sort of advanced treatment, because it can set the stage. It allows you to know what your prognosis is. How soon can you get back to golfing? How soon can I get back to hiking or going on a walk? What is the expectation of how soon I can be out of pain, or what can I do, what should I not do? So when it comes to sprains of whatever body part, the ankle, the knee, the shoulder, it is good to see the orthopedic surgeon or see me early, because I can sort of set the stage on the expectations of how soon you can get back to all the things you love to do. On that same note, oftentimes patients ask, what is the recovery time for any given surgery? And one of the things I like to emphasize is a vague question like, what is my recovery time, is not helpful to you or me. I like to talk about recovery time in terms of what activity are we talking about. So if you have a sprained knee and you say, what is my recovery time? It's only I can only answer it well in the context of, what do you want to do? Do you want to dunk a basketball? Are you talking about walking down the aisle with your daughter? These are variable parts of recovery. Your full recovery, to where you're having no pain ever, might be months and months, but your recovery in terms of, when can I drive? When can I go back to work? When can I shower? When can I go for a walk? When can I go to the gym? Those are all different, usually different answers and different specifics. And so one of the things I emphasize with my patients is, instead of just saying, what's my recovery? What's the recovery time? Let's talk about what activities you want to do, or you need to do, or desire to do, and then we can hit that, and I can give you a much more accurate answer. So carpal tunnel syndrome is probably one of the most common conditions that people come in thinking that they have and don't necessarily have it. It's also one of the conditions that oftentimes people think they need surgery for and they don't. So we see it quite often, we diagnose it, and we typically will send patients for therapy or bracing or injections, and ultimately send them for some sort of diagnostic study like an EMG or a nerve conduction study to evaluate the severity of the condition. In my experience, mild carpal tunnel is almost always amenable to non-surgical treatment. Moderate, and again, those are sort of the levels that a nerve study will come back with: severe, moderate, mild. Mild almost never needs surgery in my experience. Moderate, rarely. Severe, in my experience, usually requires surgery. So when someone comes in with symptoms that are actually consistent with carpal tunnel syndrome, that's a term that gets thrown around so much that people are quite confused about what it entails. But if we truly diagnose it here, my next step is to determine the severity of it. And based on the severity of it, the electromyographic severity of it, and the severity based on nerve studies, will determine what we recommend going forward.
My name is Martin Holguin. I'm the new physician assistant here with Dr. Johnson. I actually grew up in very small towns all over West Texas. For example, Grand Falls, Imperial, Del City, which is about an hour away from here. Very small communities. So I was able to go from those small towns to El Paso. I did 2 years at UTEP, and then from there I actually went to UTRGV. UTRGV, that's where I finished my bachelor's. I did a double bachelor's in biology and psychology with a chemistry minor. And then from there, I went to UNT Health Science Center, and I did a accelerated master's in biomedical science. From there, I was able to go to the Rio Grande Valley, there in McAllen, Texas. And that's where I did my schooling for physician assistant. There at UTRGV, there in Edinburgh. From there, I started practicing in orthopedics. So I'm a practicing PA for now 4 years. All of my experiences in orthopedics, and that includes seeing patients in clinic as well as being a first assist in the OR. The main thing I would like for my patients to know about me is that I do come from humble beginnings. I worked very hard to get where I'm at today, so I don't take this job lightly. So everything that I recommend, everything that I do is for the betterment of my patients. And I know that doing sports in the past, just being active, whether it was in the military, I did serve in the Army, the National Guard for 6 years. So just being able to restore patients to their function that they need. I've seen several injuries, whether it was in sports or in the Army. So I know that it's beneficial. Basically, what we do here. What makes a great day for me is honestly every day. I like being able to talk to patients. I do like I would say the variety of injuries that come into the clinic. That it tests my knowledge out, but it allows me to grow as a physician assistant. That's the main thing for me, is being able to see various body parts, whether it's wrist pain or knee pain, ankle pain, or lower back. It helps me grow as a provider, and it helps me better serve the community down the road.
My name's Dulce. I'm the surgery scheduler for Dr. Johnson. I've been here a little over 2 years. So my job consists of getting the prior authorizations for their scheduled surgeries, their lab orders, reviewing everything they need to follow before the surgery takes place. And then I get in contact with them after the surgery just to make sure everything is good with them, and then schedule their post-op appointments and answer any questions or concerns they may have before and after the surgery. So something I would tell the patients to make the process smooth is just to give us any questions they may have. That way the process answers all their questions, concerns, and they're not worried. Just because it's happened where before they hold all their questions and they're scared, and the last minute they're like, no, I want to cancel because I had this question but I was too shy to ask, or I was too nervous or something like that. But no, we're here to answer all questions, concerns, or anything you may have. A great day for me would be just greeting all the patients with a smile and having them also feel comfortable when they're here, answer as many questions they might have, and just give them the best customer care I can. What I like to do when I'm not working is just spend time with my daughter and my family.
My name is Carmen Marquez. I've worked here almost 8 years. It's going to be 8 years in February of next year. I do scheduling, a little bit of medical records, make appointments, workers' comp, a little bit of whatever Lisa needs me to do for her. When I initially schedule the patient, especially new ones, I tell them to come in early because there's more paperwork to fill out. I ask them to bring, if they have medical records, MRIs, x-rays, medication list, and if they need anything from us, the young lady up in the front will help them. What makes us unique here is that we're a big family. We all work together and we get along very well. And I love working with a doctor, so